Logan Baskaran, Mike Gibson coming to you live from ACC 2026, and we're talking about those patients who have a calcium score of 0. And what does it mean? Logan, what did you find?
Thank you, Mike. So I'm part of a group called the Global Probability Study of Coronary Artery Disease. It's a large registry and consortium of groups across the world looking at diverse groups and cultural, racial, ethnic groups, and to see if they've had CT scans, the demographics, the phenotypes, and ultimately the outcomes as well. And what we found here is out of 32,690 patients across 15 countries and 22 populations or sites, we found that a zero coronary artery calcium score had different implications. So these patients underwent both a coronary artery calcium score as well as CCTA for plaque presence. What we were trying to see if was is coronary artery calcium could rule out any plaque present. Now, that is typically recommended or routinely used in multiple guidelines, as well as in, clinical practice as well. What we found is it disparately had different implications. So, for example, using a zero coronary artery calcium score and then having plaque present is something we thought of as a false negative. And we found that the false negative rates depended not only on a country, but race and ethnicity as well. And what we found was that even though the prevalences were different amongst all these countries and races and ethnicities, once you adjust for all the different risk factors, race, ethnicity plus country as a surrogate variable for ancestry and environment is the number one predictor of a false negative calcium score. It is also
So,
the,
Logan,
yeah, go ahead.
what kind of demographics are at a high risk of a false negative?
Yeah, so those who are typically at a higher risk, first we'll divide it by country. So what we found is countries like from the Middle East, such as Egypt, and other parts of Asia, such as Singapore, which is where I'm from, all had higher rates of likelihood of a false negative calcium score. Now, based on race or ethnicity, again, it's a similar type of demographic, almost concordant to the countries. So, for example, Middle Easterners, uh, Black people, Asian people, and this is South Asian and East Asian people as well, all had higher rates of a false negative zero calcium score compared to a non-Hispanic Latino white population. Now, the race and ethnicities were not just were concordant with the country, but also independent of that. For example, although Middle Easterners had a higher rate of a false positive zero calcium score, they weren't all from Egypt, for example. These were also true for Middle Easterners from, for example, California or Australia.
Mm, mm. So it speaks to more of a genetic influence in some ways than just a geographic or environmental influence.
Yes, I think it's a little difficult to pass it
To
down
choose
straight
those
from.
out.
Yep. But what we find is, these are known ancestry and environment are known social determinants of health. Our prior analysis, which was presented at ESC as late-breaking science then, was that race, ethnicity plus country as a compound or as a single surrogate variable together was one of the most important risk factors for coronary artery disease, equal or more than other traditional risk factors such as diabetes, hypertension, hyperlipidemia, or a family history. But we found variations within a single race or ethnicity and across countries as well. So we can't quite tease that out, and we are hoping to do further studies to understand the mechanistic relationships between that.
Now, it's interesting. Black folks have higher Lp(a). Higher Lp(a) are associated with more rapid calcification, say in the valve, perhaps in the coronaries. So it's interesting to hear that they may have soft plaque without calcification, which kind of goes, the opposite of what I would have thought for their association with Lp(a). So do you have any insight into why some people genetically have more calcium than others, or what the environmental influences are that dictate calcification?
Yep. I think You're right. So there have been prior studies looking at Lp(a) amongst Black people and the relationship to calcification. I think the onset of, inflammation and the whole process of plaque formation and then later on damage and then stabilization is really the final end result of all these exposomes, right? And we can't truly account for it. Again, most of our risk scores, pretest probability scores, they count for these traditional risk factors, but things like air pollution, walkability in a city, so the walkability index, access to healthcare, education, all of those things aren't fully accounted for right now. I think ultimately what we want to work towards is a very population specific, and when I say population, I mean not just, again, race, ethnicity, but also geographical location, um, risk profiling for cardiovascular disease or coronary artery disease.
A thoughtful approach, Logan. Thanks for joining us today, and thanks to all of you for joining us here live from ACC 2026.